Bismillahirrahmanirrahim. I'm Dr. Naveed. I'm consultant neurologist, Allied Hospital, Faisalabad. Here I will discuss with you people epilepsy and seizure. In this presentation, I will discuss with you what is a seizure, what is an epilepsy, the types of epilepsy. I will show you different types of seizures via different videos, and then diagnosis of epilepsy, and then management of epilepsy. Now, first, definition of a seizure. Seizure is an event, not a disease. The disease is called an epilepsy. The event is called a seizure. Seizure is characterized by clinical manifestations due to abnormal, excessive, hypersynchronous discharge from a population of cortical neurons. Clinical manifestations will depend upon the area from which this discharge arises. Do not use the terms in the definition of seizure as there will be jerking or the patient will fall, because there are many types of seizures in which there is no jerking. I will show you the videos in which the patient does not fall at all. This is an electroencephalogram of a patient with a seizure. You can see normal cortical discharge over here and then normal cortical discharge afterwards, but in between there is a sudden excessive hypersynchronous discharge from a group of cortical neurons. This will clinically manifest as a seizure. Now, the definition of epilepsy. Epilepsy is a brain disorder. It is defined as a tendency to have recurrent unprovoked seizures is called epilepsy. We require at least 2 seizures to label the patient as epileptic. These seizures should be 24 hours apart. The term seizure and epilepsy should not be mixed, because not all seizures are due to epilepsy. There are seizures which are seizures, but they are not epilepsy. For example, febrile seizures, early post-traumatic seizures within 7 days of trauma. Patient may have seizures, but the patient will not be labeled as epileptic. There are metabolic seizures, for example, seizures due to hypercalcemia or hypocalcemia. Hyponatremia can lead to seizures. Hypernatremia can lead to seizures. Patients due to liver disease or renal disease can have seizures. Those patients will be labeled as having metabolic seizures, but they will not be labeled as epileptic patients, because according to the definition, the patient must have recurrent seizures, recurrent unprovoked seizures. This is the ILAE 2017 classification of seizure. ILAE is actually a body, International League Against Epilepsy, that has research and that proposes different criteria for epilepsy. According to this definition, the seizures could be focal onset seizures, generalized onset seizures, or unknown onset seizures. In focal onset seizures, there are 2 subclassifications. One is focal onset with aware consciousness, or focal onset with impaired awareness. These both can have motor onset or non-motor onset as well. Generalized onset seizures, the patient can have motor activity like tonic-clonic, like clonic-tonic activity, or myoclonic atonic seizures. In non-motor seizures, it's the absence seizures which are called non-motor generalized seizures. There are a few unknown onset seizures like tonic-clonic or epileptic spasm that have an unknown onset, and then there are few seizures that are unclassified, that cannot be classified in either of these subtypes. So this is an example of a focal seizure. There is a focal cortical discharge that can lead to a seizure. This remains focal on that side only. This is an example of focal seizure or diagrammatic animation of a focal seizure. These are generalized seizures in which epileptic discharge is affecting both the hemispheres simultaneously. This is called generalized seizure. Patient will have generalized seizures. Then focal to bilateral tonic-clonic. Focal to bilateral tonic-clonic means that patient is having focal discharge and then affects the central part from which this discharge affects the both sides of the brain. Patient will clinically manifest as focal to bilateral tonic-clonic epilepsy. This is the video of a patient with the generalized tonic-clonic seizure. So let's see what happens over here. First, there is a few myoclonic jerks, and then this is the tonic phase, during which there is a cry, there is cyanosis, or there is tongue biting. The tonic phase of the generalized tonic-clonic seizure. And then this is the clonic phase, in which there is jerking of the body. In this clonic phase, frothing and incontinence occurs. After this generalized tonic-clonic seizure, the patient has the sleep of confusion that may persist from hours. In this video, you can also see the management of a seizure. Do not put anything in the mouth. Do not try to stop the seizure by holding the arm or body. Just put the patient on left or right lateral position and do not put anything into the mouth. Is important in the management of a seizure. This is an example of absence seizure. This is called video in which a children is having electricity on the head and there is simultaneous recording of the cheek and the patient. Here you can see the epileptic discharge and the boy is not responding to the mother's command. An example of epilepsy. Here EG becomes normal and now the child is following the command of the mother. In this type of seizure, patient becomes blank, so he stares for a few seconds. Duration is few seconds to half a minute. It can occur many times a day, may be associated with eyelid twitching only, and other movements does not occur in absence epilepsy. This is an example of myoclonic seizure, which is a type of generalized onset seizure. Here you can see a few brief shock-like jerks. These usually occur, myoclonic epilepsy usually occurs in the morning. And then this is a video of tonic seizure. This boy becomes stiff. Here we can see the EEG changes. The boy has become stiff. And there is no clonic phase, so this is an example of tonic seizure. Here we can see the example of atonic seizure. It shows sudden loss of tone of the voice, the head falls, after a few seconds regains tone. But atonic seizures can occur many times a day. Now, we have discussed the types of epilepsy. We will discuss how to diagnose a patient with epilepsy. We will confirm diagnosis by ruling out differentials of the seizure. We will fit into the type of epilepsy. What is the type of epilepsy? Defining the type of epilepsy is important because there are different drugs for each type of epilepsy. Then we will evaluate the patient and then how to manage a patient with epilepsy. Management starts from confirming the diagnosis, counseling, and selecting a medication. There are special groups of patients, for example, pregnant females, old age, children. There are a few drugs that are contraindicated in special situations. Epilepsy is a serious condition. Implications of epilepsy are very much, for example, if we label the patient as epileptic, he cannot drive, he cannot operate, he cannot be a pilot or force his personnel. Diagnosis of epilepsy is clinical. There is no specific test or investigation to diagnose the patient with epilepsy. The diagnosis of epilepsy is confirmed by obtaining an eyewitness account. For example, If a patient has epilepsy of generalized type, he cannot remember what has happened to him during the fit, during the seizure. We can call the patient's attendant who has seen the patient during that episode. We will ask him the questions, what was happening before the fit, what happened during the fit. Either there was tongue bite, either there was frothing, either there was urine incontinence, and we will also ask the patient attendant or eyewitness that what happened after the fit, where the patient went into sleep. So for diagnosing an epilepsy, you should be a good historian. You have to spend time to take the history. EEG, electroencephalography, is a helpful tool to diagnose, but it needs clinical correlation because EEG has less sensitivity and specificity. So EEG should be accompanied with the proper history. Video EEG is the gold standard for the diagnosis of non-epileptic seizures like psychogenic seizures. Neuroimaging is required in focal epilepsies to diagnose structure abnormalities of the brain. We should not advise this neuroimaging like CT brain or MRI brain in all of the cases. We will advise neuroimaging only in cases when we are suspecting a structural lesion. Structural lesion in focal epilepsies, we have high percentage of patients with structural damage, so we will advise CT or MRI of the brain. Counseling is important, but it is very tough because of our social circumstances. Patients deny the diagnosis, patients label it as depression, patients label it to the seizure due to foreign bodies, due to jinns or chudails. We has to counsel the patients for drug compliance because it's the extreme important thing to control the epilepsies. Now, when to start an epileptic drug? The patient must have 2 or more seizures that must be 24 hours apart to label him as epilepsy and to start him with anti-epileptic drugs. Except patients with 1 seizure can be started on epileptic drugs when they have a structural lesion like brain tumor, arteriovenous malformations, or they have central nervous system infections or encephalitis. Without structural lesions, patients may be started with anti-epileptic drugs on first seizure if he or she has epilepsy in the sibling, or EEG is definitely positive for seizure. Then single episode of seizure may be diagnosed as epilepsy and anti-epileptic drugs should be started. Prior focal neurological deficit, patient had focal neurologic deficit means weakness of body part, or patient has status epilepticus at the onset means the patient has continuous fits for more than 30 minutes, then he should be or she should be started with anti-epileptic drugs. Anti-epileptic drugs choice is always a start with a monotherapy. Start with a single drug. If patient's fits are controlled, well and good. If patient's fits are not controlled, we can switch the treatment to the other monotherapy, other drug. And then if it's still not controlled, then we can add the 2 drugs. But always start with the monotherapy. This is the medication selection in patients with focal onset seizures. The first choice is carbamazepine, lacosamide, oxcarbazepine, lamotrigine or phenobarbital. Second choice in focal onset seizures is levetiracetam or valproate or topiramate. These are the third choices for focal onset seizures. Non-focal generalized epilepsy, generalized tonic-clonic seizures, initial monotherapy is valproate or lamotrigine. If first monotherapy fails, we will add levetiracetam. If second monotherapy fails, we will add topiramate or zonisamide. Absence seizures, the first initial monotherapy is valproate or ethosuximide. If first monotherapy fails, then we can add lamotrigine. One thing to remember is carbamazepine gabapentin, or tiagabine may exacerbate absence seizures. They should be avoided in absence seizures. Then myoclonic epilepsy. First line is valproate and levetiracetam. Second line is topiramate, carbamazepine, gabapentin, or pregabalin may exacerbate myoclonic seizures. They should be avoided in these cases. Now we have started antiepileptic drugs, and till when we should continue antiepileptic drugs? This is the time period. Seizure freedom for 2 years. If patient has no seizures for last 2 years, then we will think of tapering of, not stopping. We will start tapering of antiepileptic drugs. This tapering is effective in 60% of the chances. In 40% of the chances, when we start tapering, patient will have recurrent seizures. Then we have to start antiepileptic drugs again in those patients. Thank you for your patience listening.